Not intentionally. Can you not hear me?
No, now we
hear you.
You want to try sharing your slides real quick?
Yep.
Excellent.
Does that work okay?
Yep, perfect.
And then I'll just put it on full screen.
Great.
I think you said just for like, 15, 20 minutes. Is that what you expecting?
Yeah, exactly. 10 to 15 minutes kind of presentation, 15, 20 is fine. We'll kind of try to engage with you. This is informal. And so, the audience can ask questions as well, which is good. And then we have, it streams live over Instagram. It streams live over YouTube as well. We can get you a link later on also you can share with people. So, but why don't we get started? It's 4 o'clock. So welcome everyone to another edition of Tumor Talk. I think we've been off for a week, so it's good to be back. It's hot out right now. It's really hot over here, and I think it just started raining. But we're, as everyone knows, this is a collaborative effort between the Journal of Neuro-Oncology and Lenox Hill Neurosurgery, where we try to highlight recent publications in the journal, talk about kind of the ideas behind them, the results, as well as the relevance to neurosurgical oncology as we know it. And so we're super excited to have from across the pond, if you will, Dr. Brennan, who's presenting today on really kind of a discussion about reoperation for progressive GBM, which I think is a subject near and dear to everyone's heart, but that which we don't, have a lot of information to support or negate. And so I think it's a very interesting study. We're pleased to have you. If you want to introduce yourself and tell us a little bit about your study, it'd be great. Thanks.
Thanks, Randy. So I'll just share my screen. And make it full size. So yeah, hi. So I'm Paul Brennan. I'm based over in Edinburgh in Scotland in the UK. And as Randy said, the intention of doing this piece of work really was to generate discussion. So it's great that I've got an opportunity to get some feedback on that. I think that the challenge we all have as neurosurgeons is knowing when to do things as much as how to do them, and this project's really born out of that. If you're not familiar with Edinburgh, I'm just going to give you a couple of quick facts about the place. So there is a couple of famous neurosurgeons in Scotland. The first one, Norman Dott, allegedly one of the first people to wrap an aneurysm quite a long time ago. He founded the centre in Edinburgh. This is a short walk from where we're based just now. And Graham Teasdale, you may use the Glasgow Coma scale in the US. I think quite a lot of people do. So he's based just 50 miles away from us in Glasgow. So Edinburgh, Glasgow, pretty close geographically, not so close intellectually for many years. And they were sort of quite disruptive in terms of their antagonism between each other. But I work very closely with Graham Teasdale now on trauma stuff. So that's Edinburgh. My main work there was in tumours. I'm predominantly a tumour surgeon, and I split my time between research and surgery. And I guess my main interest is in the sort of the beginning of the journey for a patient with cancer. In the lab, my work's focused on cancer initiation, and I do quite a bit of work on blood biomarkers and prognostication before diagnosis. But surgery is obviously key to what we all do and what we practice. But the sort of the question of what do you do when the tumor comes back is something really that closes the loop for me, because when we think about tumor initiation, really we also need to understand how the tumor is going to evolve over time. How is it going to respond to treatment, and therefore what we're going to do when it comes back. And so really that sort of left hand side of this diagram represents a lot of what I did. And I just included a little diagram I use in some other talks at the bottom. One thing we try and do in Edinburgh, and I don't have time to sort of go into it in any detail here, is really do research that goes all the way from the patient down to the molecular data. So we've got quite a lot of neurosurgeons doing some very good research in Edinburgh, and quite a strong brain cancer research program, not just run by surgeons, but across all sorts of disciplines and preclinical scientists, and really trying to link that whole process together, and to not distract from the fact that fundamentally it's patients that we're trying to treat. And this study really came out of that whole conversation, because you know, in the lab, we've got guys working on mice, and they you know, make their predictions about which genes are important for cancer. You know, they give drugs. The drugs seem to kill the cancers in mice. Everyone thinks they've cured cancer, wonderful. But time and time again, these things make no difference to what we do in the clinic. And one of the things that I've really struggled to get my colleagues in the lab to consider is this whole question of tumor progression. You know, what happens after your initial treatment, once we've done our surgery, once we've given our chemotherapy and radiotherapy, and what happens next? Because the survival of patients depends on what happens at that stage. It doesn't really depend on what happens at the tumor initiation stage for a lot of what we do. And in the UK, we follow this really. So at the point at which the patient comes back to the multidisciplinary meeting, most patients will get one of these 4 treatments. So all patients will get one of these 4 treatments. Most patients will probably be re-challenged with some chemotherapy. Those who survived more than a year will probably get some more temozolomide, Temodol. Those patients who haven't will probably get best supportive care or some lomustine. Very few of our patients get offered surgery, and incredibly small proportion get offered redo radiotherapy. And you know, we could spend the whole day talking about why that is, but this talk is just going to focus on this question of why, who gets surgery, who should get surgery, and is it useful at all? And you may be familiar with the papers that have been published on the topic. There's a couple of really good systematic reviews from the last few years. The one that's been cited the most of the two is this one from Victor Liu and colleagues. So they did a meta-analysis of, or a systematic review, more than a meta-analysis, but of 8 observational studies. So there's about 2,000 patients altogether in their study, and they come out with this headline statistic that if you have a second surgery, you do better than people who don't have a second surgery. And it's clearly a very difficult statistical analysis to pull off. I mean, the data you're analysing is predominantly of patients who have had second surgery, patients who've probably tolerated their chemotherapy and radiotherapy better, patients who've survived longer, and then they have a second surgery, and then they have more chemotherapy or TTF or whatever it is. And it's really hard to disentangle all those things. But actually, we've not really made a huge effort in the surgical community to try and disentangle them. We rarely present data that compares people who've not had surgery with people who have. We more often just present our case series of patients who've had surgery. There was a group there who came along shortly after and presented this meta-analysis, which was incredibly thoughtful. And although it's not been cited as many times yet, I hope it does go on to have as big an impact. They looked, instead of saying that, you know, age might be important, gender or sex might be important, surgery might be important, they decided which variables were time dependent and which weren't. And clearly surgery, second surgery, is a time dependent variable. At the outset of when you have your surgery, your first treatment, you don't know that you're going to get second surgery. And so in their modeling, if they just treated surgery as a black and white, yes or no, second surgery as black and white, yes or no, they came out with the same statistic as the systematic review, which was a hazard ratio of 0.66, a significant association with second surgery. But if they treated it as a time-dependent variable, and by this I mean the time from first surgery to second surgery is important, it's not just whether you have second surgery, then actually the importance of surgery diminishes quite significantly. In fact, it was no longer significant. And so that for me really captures something, which is what I was seeing in the clinic. You know, I don't see these patients get better very often. I obviously, you know, I do second surgery. I do think it's useful, but I wasn't sure who to do it for. And this was a patient of mine who really convinced me of that. And you don't need to comment on the quality of my surgery or our imaging or anything else. This is just a mem for me, right? So this was a young guy who'd had a tumor, I think 3 or 4 years previously, and I'm a fairly new consultant neurosurgeon. I'd not done his first surgery. He came back and there was a suggestion that this was progression. We weren't sure, could it be pseudoprogression? A few months later, it seemed more obvious by April 2018. And he said, well, you know, surgically, that's reasonably easy to target. So we'll go in and we'll target it. And post-operatively, you know, I was very generous with the bounds of my surgical excision. I had a big hole. The patient was fine. Everyone thought he was wonderful. And literally a month later, The guy's admitted to intensive care and dies. And, you know, we didn't do an autopsy. I don't know for certain that that what's growing around the outside is GBM. Radiologically, that's what they diagnosed. But this is almost this is another group of patients I see. I see the ones who do benefit from first surgery and second surgery, but I see those for whom it seems to make no difference. And that's the background, right? So we did this study, and I didn't want to present another case series from a single center institution where we say that probably surgery is good. I wanted to try and disentangle that problem of why do we think surgery is good and how are we going to prove it in the future? And so with a group of surgeons and oncologists from across the UK, we put together this project where we tried to ascertain practice across the UK, Europe and beyond. And we did a retrospective analysis across the UK, knowing that both of these are flawed. You know, we didn't survey every neurosurgeon, we didn't survey every oncologist. We don't know whether their views were consistent or representative of the departments they worked in. So any caveat you can think of, but we were looking for understanding that variation. And you can see from the Google map that we sort of surveyed quite a broad geographical area. And I just want to highlight a few key things, and key in terms really of where we want to take this work next, and you know, the sort of feedback that I'd value from you guys. So I find this imaging quite paradoxical. So in the first year, after you've had surgery, we scan everyone every 3 to 4 months. But once the person survived more than a year, and you know, the median survival in the UK and Europe from GBM is 7 months to first progression. It probably is the same in the US. You know, we've got these statistics that the good patients do up to, you know, 12 to 18 months. Why, when the patient is more likely to be a good responder, a good survivor, do we stop scanning them if it matters when we identify when progression is? And I've always found that a paradox, and I was surprised that we saw that perpetuated across the whole of the cohort. A thing which is clearly important is it's got to be about quality of life. You know, whether or not we think that surgery helps, we have to help the patient. And that speaks to performance status. You know, if you come in with a good performance status, you'll probably go out with a good performance status. But then, is age important? I mean, I've seen, even over the course of, you know, the 15 years since I first started neurosurgical training, I've seen a massive change in the age at which we treat patients. People didn't really think it was important. But where does that balance lie between functional status and age? Because there must be something in that. We know that age is an independent predictor of outcome, and we know that fundamental is. So we were beginning to sort of see the variation, trying to unpick what people might think is important. We asked them about MGMT. Most people didn't measure it routinely. So, sorry, I've got it the wrong way around. I think only 25% measured it routinely. And of the patients who did measure it routinely, most people thought it was unimportant. I think that's, you know, these responders were predominantly neurosurgeons. Maybe if we had predominantly oncologists, they might have had a different view about that. But we asked the surgeons to speak to the oncologists. We wanted this to be an MDT response. So, but I think that was quite telling. There's still an uncertainty, certainly in the UK, and probably into many bits of Europe, about the role that MGMT has. And it doesn't seem to have a role for many people in their decision-making at progression. Most people didn't seem to think it mattered, or many people, sorry, didn't seem to think it mattered to get more than 90% resection. And I think that's one of the key features. If we're trying to tie in the sort of the functional improvement and the maintaining quality of life, I think understanding what we're aiming to resect and why we're aiming to resect is important. So, and then timing. So STUP for us, I hope it's the same for you, is concurrent 6 cycles of temozolomide whilst you're having your radiotherapy, 60 grays in 30 fractions, and then followed by another 6 cycles of adjuvant. Almost half of people thought you should have completed that before you got your next stage of treatment, but not everyone. And so we took that big variation and we looked at some of those same factors in the cohort. So we only looked at 300 patients from 6 units. So the population in the UK is about 70 million. The 6 units we picked were 6 of the more of the units that serve the bigger populations, but it's still not a very big cohort. But there was just, this was the sort of the key thing we wanted to see. So In the patients who had a second surgery, their median survival was 815 days, so far beyond the average survival of people who weren't treated with a second surgery. But the second surgery wasn't what gave them the survival. So it was a time between first surgery and second surgery that contributed to their big overall survival, not the time from second surgery to death. And you may have experienced that as well. And it's what that sort of second meta-analysis spoke to. The proportion of adverse events actually wasn't that bad. 23% may sound high, but people were reporting 17% after first surgery. And they were being quite diligent about how they reported them. So it probably overestimates what many of us would call a complication. But what to make of all this then? So yes, it's a snapshot of practice. I could ask the same question to a different group of people and maybe we'll get different answers, but I think we'll get the same spectrum of answers and we'll get the same level of uncertainty. And for me, it's that heterogeneity and that variation which is important. We've got a big data science centre for brain tumours in Edinburgh, and we spend a lot of our time trying to understand at a population level how data that's routinely collected actually tells us about brain tumours. If you don't have consistency in which factors people think are important and which bits of data people record, you actually can't resolve these problems. So in some ways, just trying to unravel that heterogeneity is the first step. The fact that we have missing data, the fact that when we do the cohort analysis speaks to the low rate of surgery. How are we going to solve this problem when we're only operating on, again, fewer than 10% of people who have primary surgery have secondary surgery? It's going to take us a long time to collect data unless we multiplex it over a large geographical area. But clearly, there's no overwhelming evidence that second surgery is an independent predictor of outcome. So from our point of view, we want to sort of move this forward, and I'd welcome people's input, either positively or negatively, about what we've done. Diagnosing progression is not straightforward. If we're dependent on imaging, which is performed at fixed time points, how are we going to determine when disease progression happens, and how are we going to determine which patients really benefit from intervention? Can we come up with some consensus criteria for second surgery? And I've got a table just on the end in a second. You know, the minimum time from first surgery seems important, but how are we going to agree what that is? Is 9 months enough? Is it too much? If the median survival is only 6 to 7 months, is 9 months unfair? Should patients be expected to have a good outcome from their second surgery in terms of tumor resection? We're probably mainly agreed that extent of resection is an important outcome at primary surgery, so why should it not be at secondary surgery? Beyond all this though, is surgery just about taking out the tumor and improving survival? What about surgery as access to vaccine studies and molecular analysis and everything else? And I think that's the big caveat to this, is it's not about restricting access to secondary surgery, it's about deciding who benefits from when they do. So we propose these criteria, and it might be a good slide to finish on, but it's, you know, we'd like to use these not to mandate what people do and don't do, but to try and develop a group of, you know, surgeons and researchers who can work to the same plan, and from that collect a data set from which we can try and address these questions. So that was all I was going to say. I'm happy for people to contact me, but I'll flick back to that slide because I think that's the most interesting one, if I can work out how to go back. But thanks very much.
Oh, thank you, Paul. That was great.
Yeah, thank you, Paul. That was great.
And yeah, I agree. Just hovering on this slide for a minute. I mean, you know, obviously now you've kind of had a conversation with, you know, over 200 surgeons throughout the world for the most part. And do you think that these criteria are stuff that you've derived from that kind of conversation, this questionnaire, or are these what you've been doing in your own practice that you think you've got enough, you know, data for to support?
No, I've tried to do it from those 200 or so surgeons, and then when we'd come up with that, we sent it back around the UK and said, what do you think about this? And there were things on it before which we dropped out, which people just felt uncomfortable with. So the age was in there originally, and we dropped age out altogether, which I think made sense. Originally KPS, I would probably put it higher than 70. I mean, 70, you're pretty dependent.
Yeah.
If you use Canofsky performance status, but I mean, that's really someone who's not got a great quality of life, and you sort of talk about perpetuating that. So, but we tried to make these as conservative as possible. So yeah, it is consensus as it stands. But it'd be interesting, you know, we weren't well represented in North America, so I don't know how well these fit with what you might do in your practice.
Yeah, I mean, obviously needs to be studied, but I think you nail a lot of the key points. And I think, a lot of these points, one thing that's important is that they're kind of surrogates for other points, right? Like we always talk about tumor location. And so someone who's got an eloquent, GBM is not going to have a KPS greater than 70, or they're not going to be able to get greater than 90%. So you kind of weed out cases that are going to be technically difficult or may have, more risk than benefit. I guess my other question for you is, do you think that something like super total resection in the initial setting, anything that prolongs that time between first and second surgery, may argue may argue against second surgery?
Yeah, it's good. It's a good question, isn't it? And I think that's what's interesting in some of the case studies people present, is how it can flip both ways. That sometimes more aggressive treatment at the first time gives you all that benefit up front, and you get less benefit from the next set. Mm-hmm. I think the only clinical trial I'm aware of in surgery of progression is a Swiss study, which is essentially a study of right frontal lobe gross total resection. And yes, that probably is a good treatment for right frontal lobe gross recurrent surgery. But what's more interesting is that a lot of the data that's reported, people are operating on recurrent tumors in eloquent areas when they can take out less than 90%. And why is that? And if if as a community, we can sort of navigate our way to why we're doing these different surgeries, we can find that sweet spot, because I hope it's not just right frontal lobes. I hope there are a group of people who can benefit. But I think at the moment, it seems, it's certainly from what's reported and in my practice and what I see others do, it seems a bit uncertain. And ultimately, in terms of understanding the biology of the disease, I think until we can be certain what our clinical observations are, it's hard really to work out what our biological observations are, and that's where the real treatments are going to come from. The new drug therapies and the new radiation therapy schedules and stuff.
Yeah, I agree with you, and I think that we could sit here and debate, tumors arising in certain locations that have been treated with so and so, all day long, and I think ultimately it requires kind of number one, study, and like you said, understanding the molecular basis of these things and which ones actually may benefit from a surgical resection or not. So how do you move forward now? How do you study this to see if this is good criteria, or should it be modified again?
Oh, it should definitely be. I mean, it should definitely be modified again. I wouldn't like to think that you can come up with a good list to start with. So there's the two ways we're using this. One is to try and create a standard data set. Because if we could collect this data from consecutive patients in every hospital, both those who have surgery and don't have surgery, we would then start being able to address these questions better. I mean, most observational studies don't have a case control, which is just a massive weakness to start with. And then secondly, trying to rationalize what that pragmatic trial would look like. Can we recruit patients into a study of surgery where there's genuine equipoise, where we can do something? And I struggle with that. We've tried to work through hypotheses for years, but I think that as a starting point, better observational data, better case control data would be a good place to go. And hopefully in that process, we start addressing some of these things you mentioned, about molecular diagnoses and better stratification of patients.
Yeah, absolutely. Well, Paul, thank you so much for coming along. Nitesh, you have anything else to add?
I think that's covered. If you can go back to that table you had, I think the interesting point that is the first thing actually is the MRI T1 post contrast, and the value there being sort of incontrovertible evidence of disease progression. I feel like the rest of these criteria are pretty cut and dry, but that one, depending on institution, especially our institution, you see our tumor board, even within a specific discussion, there's quite a bit of variability. So I feel like that might be the toughest one. But this is very succinct. It's organized. It's a really nice framework for thinking about this. And I think this adds a lot of value to our thought process for this entity.
Well, I'd certainly welcome if people are able to collect data against these, and we could do that internationally. I think we've got a good starting point for trying to do an observational study. And I agree that the incontrovertible evidence of disease progression is the real elephant in the room, because if we don't know when the disease is not recurrence, it's not tumor recurrence, because it never goes. If it's not recurrence, it has to be progression, and therefore we need to know when progression happens. And radiologically, we can't do that. I'm not sure we'll ever be able to do that. And there's lots of people, us included, working on biomarkers. I'm not convinced that we will end up with incontrovertible evidence from biomarkers. So, but we've got to somehow solve that, I think, because otherwise we're all talking about slightly different things when we talk about disease progression.
Yeah, absolutely. Well, Paul, thank you so much for being on board, and thank you so much for publishing the paper in the JNO. I think it's a great paper. It's great to see the opinions of so many surgeons worldwide, and have it consolidated and organized in a very thoughtful manner, kind of like you said. So, like I said, this will go up on YouTube. You'll be able to share it with folks. We'll send it your way, and we appreciate you stopping by.
Great, thanks, Randy.
We'll see you next
Thanks,
time.
Paul. Take care.